Hi, good morning. My name is Dr. Raja Adnan Ahmed, and I'm a psychiatrist. I work in UK. This presentation is part of my common interview question series, which is for the benefit of the IMGs, the question they may encounter in an NHS job interview. And this particular video is focused on the common emergencies that may come in an interview situation if you're going for a middle grade or a junior doctor in psychiatry. So please note that this presentation is for education only and it's not clinical advice. The cases I will talk about are all hypothetical. Practical training, experience, and expertise is required if you're trying to prescribe medication or deal with emergencies. So please consult with your senior if you are working in a clinical situation. Don't take my advice from this presentation as a clinical advice. So the learning objectives from this presentation is to discuss the common psychiatric emergency which may come in interview setting if you're going for a psychiatry interview and how to answer them. So remember, I'm not trying to give you any model answers. I'm just trying to explain to you the concepts and theory behind those questions and how can you structure your answer. You will have to come up with your own answer. You have to do some of your own reading and research to make those answers look good. So let us start. So the common psychiatry emergencies uh, which we encounter in a job interview. I mean, the most common one is self-harm and suicidal risk assessment, very common for junior job, or if you're going for a middle grade job as well. It's very common in exam as well if you're going for any exams to assessment of self-harm or suicidal risk. Then uh, assessment of alcohol withdrawal, identifying alcohol withdrawal because this could be life-threatening as well. Refeeding syndrome is something else that has been asked in the job interviews. Postpartum psychosis, and then acute confusion states. Then there are some emergencies which are related to medication, includes serotonin syndrome, Neuroleptic malignant syndrome, lithium, and then some issues around the rapid tranquilization. So I will talk about all of them in a minute. But to just to acknowledge that, when you're going for a job interview, you need to understand what kind of team, what kind of service you are going for. So depending on the subspecialty of psychiatry, the question and the answer may be a bit different. So, for example, if you're going for addiction psychiatry, they might ask for alcohol withdrawal a bit more. If you're working for child psychiatry, self-harm, refeeding syndrome may be a common one. So, need to understand what kind of interview you are actually going for, and then look for the common emergencies that can happen in that particular setting. One of the commonest scenario or situation you may be asked about is self-harm and suicide risk assessment. You may be given a case synopsis that you are on-call doctor or doctor working on a ward and you've been asked to assess a patient who have self-harm thoughts or have done self-harm or attempted suicide recently. You may be asked to go and see this patient in a hypothetical situation in an accidental emergency department or a via assessment via GP. So the main aim they're trying to assess is that can you carry out a basic and good self-harm and suicide risk assessment? And the candidates who have done PLAB, and this is important to note that this is a similar thing which you may have done for your PLAB exam as well. So if you can repeat that or you can revise that, that will be also helpful. But basically, in self-harm and suicide risk assessment, you need to acknowledge that self-harm and suicide can overlap, but they are two different things. A comprehensive history is required. Background, including the background history, the past psychiatric history, and what happened during the episode. But the first thing to say, if this question is asked to you that somebody has done self-harm, how do you approach that situation? The first thing to ensure is the patient is medically fit and stable. So in case of somebody taking overdose or somebody who's attempted to harm themselves in any way, you need to make sure that if there's any physical harm done to the patient, they have been looked into by the medical team if required, and the patient is hemodynamically stable for you to assess them. The second thing about the self-harm and suicide risk assessment itself, I think it's important to acknowledge that we need a lot of background information. So even prior to seeing the patient, if you have access to their records to understand what has been going on, it's important to note that any past psychiatric history, any previous attempts, any history of mental illness in the past, and their social circumstances. If you can establish that background information, that will help you. Then when you're actually seeing the patient, it's important to mention that it is essential that you establish good rapport and you show good skill to communicate with them, because a patient who has just done self-harm or suicidal attempt may be very stressed, and they may not open up to you very openly. So establishing a good rapport, having a non-judgmental approach, good listening skills, these are very very important skills that you can use to establish uh, to gain their confidence and establish rapport and then take history. Then after establishing rapport, you can mention about how will you actually do the assessment. So what sort of things you can ask. So if this is about a self-harm or suicide risk, you can ask what was actually happening around that time when that event happened, what was happening prior to that episode, if they were going through a difficult time in their life, if they were what thoughts were going through their mind, what social circumstances were that led to that episode, what happened during that episode, and what happened after that episode. Did they try to lock themselves in? Did they inform somebody after that? Did they left a suicide note? All of those things are important, help to establish the risk assessment. And it's also good to acknowledge that you need to have history of any mental illnesses at the present point in time or also in the past as well, which will be very important. Then it is also an important part of assessment to see the further thoughts or plans, because then this is how you will establish if the patient is safe to go home or they need more intense treatment like an inpatient admission. The next slide is basically just a few factors which I've taken from internet, that if you're taking history of self-harm suicide risk assessment, what kind of factors you can include, what things you can focus on. But I think it's in this, if this is asked to you in an interview situation, they are trying to establish if you can identify a patient who are at high risk, medium risk and low risk. Unfortunately, there are no scales there to help you. You cannot have done a tick box exercise to see if the patient is at high risk or low risk, because those scales does not really work, and there's no evidence they will work. But from your clinical uh, judgment and good history, you can establish if the patient is a low risk, if they can be discharged home, with what kind of support would be required, or if you think the patient is at a moderate and high risk, you can escalate it to your senior and see if the patient will need to come in as an admission. This is what they're trying to really establish. If you can do a good assessment, show them that you know the step of the assessment, and show them that you can identify the risk and then escalate it if required. So next we will talk about alcohol withdrawals. I think this is very important in a psychiatric setting as well, and it comes in exams as well as interviews too. So for example, they can give you a case synopsis that the patient who has been, you've been asked to assess a patient who was recently admitted to a psychiatric ward, or they may have been admitted to a medical ward for a medical treatment or a surgical ward. But after 1 or 2 days of admission, the nursing staff is reporting the patient is getting very distressed. They're getting psychotic. They're getting hallucinations, paranoid thoughts, and this is all very acute presentation. I think if that history is given to you, it's important to see what has actually happened. Try to exclude the other things as their physical cause for their acute confusion. But one of the things to consider is that what if they are going through alcohol withdrawal? Just taking good history of alcohol use and to see if there's any past history of excessive alcohol use, and if suddenly they've stopped alcohol and gone into withdrawal. So the severe form of alcohol withdrawal can be life-threatening, can lead to Wernicke's encephalopathy, and also brain damage as well. Usually, it will take 2 to 3 days for patients who are using a lot of alcohol to for them to stop drinking and start developing the alcohol withdrawal symptom, but could be sometime earlier than that. And the severe withdrawals can usually last for 1 to 5 days, but in some cases longer than that as well. So these are the common symptoms which you will see in alcohol withdrawal. You can see the patient may have tremor, sweating, pale skin, confusion, hyperactivity, anger, hallucinations, visual hallucination can be reported as well, fever, dehydration, nausea. Sometimes they can have fits as well and leading to death. DTs, the treatment for that is normally, this treatment First, you need to identify this is definitely alcohol withdrawal that the patient is going through. And if that's the case, then the treatment can be given on psychiatric ward as well if this is a mild to moderate case. If it's a severe case where there's risk of fits and all that, you may require the patient to go to the medical ward. But in terms of treatment, the common treatment given, the benzodiazepine, they can be given as a single dose. Sometimes if the patient is going through active withdrawal, or on a sliding scale as well, we use diazepam, chlordiazepoxide, lorazepam. But it's also important to acknowledge that thiamine replacement therapy is very important because that will help the patient's uh, neurons. They can help the patient from the brain damage that can happen um, as a form of following an alcohol withdrawal. Um, and sometime in a case, an you where maybe asked if a patient uh, is uh, is with psychotic symptoms, hallucination. Why can you not give them antipsychotic? Why can't you prescribe an antipsychotic? We try and avoid antipsychotics in these cases as we know that they increase the risk of fits. So if we can avoid them, that's the best. And if they can manage the patient with benzodiazepine, that would be our first choice. DT, there's something called SIVA scoring system, which is very commonly used in UK. So if you're going for interview, I think it's good to sort of familiarize yourself with SIVA, and when it is done, it is available on internet. You will find it very easily. SIVA scoring score patient on the common symptoms of alcohol withdrawal, which you can see on the screen. And by the scoring system, you can come up with an idea that if this is a mild withdrawal, moderate withdrawal, or severe withdrawal, and then we can give the patient treatment according to that. Next, we will talk about refeeding syndrome that can come up as a question in your interview, especially if you're going for a child psychiatry interview or going for a service which deals with cases of anorexia nervosa and other eating disorders. So refeeding syndrome question can come as that there's a patient known to have a history of anorexia, and they have a restrictive diet pattern, but suddenly they started to eat a bit more, and now they're feeling very unwell. What could be the cause? Something on those similar lines, that the person who was malnourished and now suddenly started to feed again, and they are experiencing some physical health symptoms. So it's important to acknowledge that refeeding syndrome can happen in these cases. Simply speaking, refeeding syndrome, as I said, is introduction of food too quickly after a period of not eating. This can be potentially fatal, and it can lead to electrolyte imbalance in the body. Um, in context of psychiatry, anorexia is one of the conditions where we worry about this patients to go through a refeeding syndrome. So we have to be very careful when we are feeding them again, when they start to feed them again, then we do it gradually and do it in a way when we are closely monitoring them. This diagram simply explains what really happens in refeeding syndrome. If you find this diagram a bit more complex, you can find simpler explanation on the internet as well. But it's as simple as when the patient is not eating, they don't have carbohydrates in the body. When they suddenly start eating, there's a load of carbohydrates, which leads to increased insulin secretion, which leads to some electrolyte imbalance, and that can lead to symptoms and medical complications. These are just the symptoms of refeeding syndrome, starting from double vision, swallowing problem, problem with the breathing, problem with the kidney, muscle weakness, confusion, disorientation. In some cases, the patient can suffer with fits as well, nausea, vomiting, low blood pressure. And in terms of the clinical features, if you can do physical health examination to identify the patient who's going through refeeding syndrome, but you can also send some investigations as well, which I mentioned here, which include normal electrolytes and some additional tests as well. Um, Now, it is important to acknowledge that refeeding syndrome is a medical emergency, and these cases generally are not being looked after into a psychiatric ward. If you identify a patient who's developing refeeding syndrome on a psychiatric ward or while they are at their home you need to contact the medical team and talk to them about this, because they need the medical admission and close monitoring, because the electrolyte imbalance can lead to serious effects on their vital organs. Next one is postpartum psychosis. You maybe ask this in a way that you are asked to assess a young lady who has suddenly suffered a psychotic episode. They may or may not tell you the lady has recently given birth, or you might have to ask in a history if there's a history of recent childbirth. Postpartum psychosis can happen within a few days of a lady giving birth. That may include psychotic symptom, delusion, hallucination, a feeling of fearfulness, suspiciousness, depression, manic symptom, rapidly changing mood, agitation, anxiety, all of that. Um, Postpartum psychosis can be a very significant psychiatric emergency as the patient can put themselves at risk. They can stop eating and drinking. They may not be looking after themselves. They not be looking after the newborn. In some severe cases, the patient can hurt themselves, have start having suicidal thoughts, and can have thoughts against their newborn child as well. And there are cases when people have hurt their own babies. So it is very important that these patients are closely monitored, their symptoms are closely monitored as well, and the newborn is also closely monitored. In terms of management of postpartum psychosis, they will most probably require hospital admission if they have significant symptoms. In UK, we have something called a baby and mother units that is specifically for patients who are suffering with postpartum psychosis, where both the patient and their child can be admitted at the same time and looked after very closely. The treatment generally include antipsychotic, mood stabilizer, antidepressants, when the patient is more stable, we can give them therapy and some support as well and monitoring. However, if this question is asked to you in an interview setting, if you have identified the patient as postpartum psychosis, it's important to do risk assessment, which include risk to themselves and the newborn child, and then escalating it to your seniors, looking for a baby and mother unit if required, or hospital admission. Acute confusion state, which you may encounter in different several setting in psychiatry while you're working in psychiatry, especially if you're working in old age psychiatry. So acute confusion state, also called delirium, which is a clinical syndrome characterized by a disturbed consciousness, clouding of consciousness, cognitive function can get affected, including the patient may develop hallucinations. This is normally in a very acute onset, and you will find the course is fluctuating. But as an interview question, you may be asked just like this, that you have been asked to see a patient who have diagnosed with Alzheimer's, but they, for the last 12 hours or so, they are very psychotic, they are hallucinating, they are very agitated and aggressive. You will always consider that what if on top of their chronic confusion state, which is Alzheimer's, there is an acute confusion state and some other reason. The reason could be, most commonly in older, it happens in older patients, but it can happen at any age and younger patients as well. Confusion secondary to a physical health condition is something which we have to consider. So in those cases, you can say that you will assess the patient, you will examine them and see if you can find any reason for their acute confusion. Has there been any changes to their medication recently? Is there any indication of a physical health condition, a concern, an infection, urinary tract infection? You can send them routine bloods, dip the urine, send the urine for culture as well. Acute confusion state, and especially if the patient is going through a period of infection, this can turn into sepsis and can become a medical emergency and can lead to death as well. So we have to be quick in identifying if there's any underlying cause. The underlying cause could also be due to dehydration, electrolyte imbalance, due to constipation, things like that, pain. So we have to consider all of those things if we have been asked this question in an interview setting, that how would you assess this? In terms of treatment, as I said already, identifying and managing the possible underlying cause is the first thing. But in terms of managing the patient, how do you approach that? If a person who is very confused and agitated, effective communication and reorientation is very important, which means that try and develop some rapport with the patient, try and reassure them that they are safe. The patient might be feeling very scared, agitated. Reorientate them, tell them who you are. You might have to tell them repeatedly in a calm and nice voice. And then reorientate them to the surroundings, to tell them that they're in hospital, they're in a safe place. That may be useful. Then you may have to find a suitable and safe environment within the ward. Sometimes when the ward are too noisy, that can lead patient getting more agitated. So finding them a quiet space, well-lit room, those sort of things can actually help. If the patient is very agitated, you can use some verbal and non-verbal techniques to calm them. But if you ask specifically about medication, haloperidol is something that is recommended by NICE. So these are nice guidelines. They will always talk about using the non-pharmacological methods first. But if they are not useful, then you can try medication, but you have to be careful when you are prescribing antipsychotic to elderly patients. There are side effects. You have to be mindful of that, as they can make situation worse. But they are mentioned in the guidelines, so you can actually use them if you are asked in an interview situation. So next we will talk about medication related psychiatric emergency. There are some psychiatric medication which can lead to emergency situation, and you may be asked about that in an interview setting. First, we will talk about serotonin syndrome. This is a very well-known condition, and you can read a bit more about that on internet if you're going for a psychiatric interview. Basically, it means that the antidepressant medication we use can increase the serotonin level in the body. Sometimes this level get too much, and that can have adverse effect on patient's health. So the case they might give you may sound like this, that you've been asked to see a patient on the ward who is feeling very agitated, confused. How will you approach that? So obviously you will do the routine things you do. You need to take more history. You need to find out what has been going on. One of the things you will check that with them is that if they have been started on a new medication, and if you get a history that they have started on a new antidepressant medication or a combination, and after that they started feeling unwell, then serotonin syndrome is something that you need to consider. And it can begin within few hours of taking new medication as well. This is something important to acknowledge. These are just some common symptoms of serotonin syndrome. Patient can have diarrhea, hypothermia, hypertension, tachycardia, agitation, confusion, hallucination, tremors, myoclonus as well, hyperreflexia, seizures in some severe cases. This is just a slide to see if you want to remember that. You can remember it this way. The diagnosis of serotonin syndrome, as I said, is sometimes diagnosis exclusion to see if there's nothing else going on. And the main thing is that after starting medication, they develop these symptoms. There are no tests, unfortunately, no blood tests to confirm. History is very important, history of medication and physical examination. But if you identify that serotonin syndrome is happening in a patient, and this is why they're unwell, urgent referral to medical team, escalating that is important to make sure the oxygen level and blood pressure under control, stabilizing the patient. Sometimes we can use benzodiazepine as well, but to be honest, if the patient is that unwell, we normally escalate it to the medical team, and they are looked after in the medical ward. Similarly, there are some medication to block the effect of serotonin, but we don't really prescribe that in psychiatric wards. This is something that will be done in the medical ward. So you can, from the interview point of view, if you have identified a serotonin syndrome, you can talk about a bit about the symptoms, what is normally expected, and then escalate it to the medical team, identifying that as a medical emergency. Next, we will talk about the Neuroleptic malignant syndrome. This is very commonly asked. I think it's asked probably more than serotonin syndrome in the interview setting. NMS, Neuroleptic malignant syndrome. This is a rare, but it could be a life-threatening condition. Neuroleptic malignant syndrome is reaction to antipsychotic medication, basically. And it can develop within a few first 2 weeks of starting new treatment, which is normally a new antipsychotic medication, or sometimes if you give in a combination of antipsychotic medication to the patient. So in the interview setting, they might ask you, that there's a patient on the ward or in the community who suddenly became very unwell and they're confused, agitated. What could be the cause? You will again do the routine things, ask for the background to see if there's any physical health cause for that, any history of recent infections, things like that. And then you will come to the medication history to see if they were starting to order new antipsychotic medication. If you found that after a few weeks of starting antipsychotic medication, these symptoms are appearing, then you will consider the possibility of neuroleptic malignant syndrome. The Symptoms of neuropathic medical symptoms are on the slide. This just includes high fever. The body can get very stiff, autonomic instability, agitation, confusion. And it's important to acknowledge that there is actually a test which we can help to diagnose neuropathic malignant syndrome, which is unlike the serotonin syndrome where we don't have a test. So serum CK level can actually help you identify if the patient has NMS. In NMS, the serum CK would be very high. The treatment is just to stop the causative agent and referral to the medical team. Again, this is medical emergency, and untreated NMS can lead to death as well. Sometime, patient can be left with a long-term damage to the brain. Supportive care is required. If you want to learn more about that, you can find resources on internet about NMS, but there's up to date here. But in terms of interview, and this is asked in an interview setting, if you have identified the patient has been started on new antipsychotic, or the dose of the antipsychotic has been changed, or a new combination of antipsychotic has been started, and following that, if patient has developed these symptoms, then your course of action would be to escalate to the medical team, stop the agents, the medication which is giving them these symptoms, and then the patient needs to be looked after in the medical ward and given the supportive care. Now, this is something sometime it has been asked in the interview setting, but this is a very common question which can come in psychiatric exams about you see serotonin syndrome and neuroleptic malignant syndrome can look very similar on paper, and how do you how can you identify which one is serotonin syndrome, which one is NMS? So basically serotonin syndrome medications are the ones which we give for low mood and depression. For neuroleptic malignant syndromes, normally the antipsychotic medication. Physical health examination finding, yeah, there's a bit of they can look similar, but they are things you can separate from. So in serotonin syndrome, you get hyperreflexia, myoclonus, problem with the eyes, whereas in neuroleptic malignant syndrome, you will find the body is very stiff and they have hyperreflexia. Laboratory finding serotonin syndrome does not really have a test, but if you are looking for neuroleptic malignant syndrome, you can send the routine blood test, which will also include CK levels. And then course of illness, serotonin syndrome normally develops relatively quickly, starting right after starting medication within 24 hours. Neuroleptic malignant syndrome can take a bit longer than that to start. Lithium is another common medication which is used in psychiatry, and lithium case can also come to you in the interview setting. Lithium is prescribed for bipolar and treatment of depression, which is not responding to our routine medications. Lithium is known to have narrow therapeutic index, which means the level at which lithium is effective and the level it becomes dangerous for the patient is very narrow. So we have to closely monitor and regularly do the lithium bloods. The optimal range usually between 0.6 to 0.8. Anything above 1 is considered an high range level, and we need to make sure that we are keeping a close eye on patients who are on lithium, and by doing their regular levels, especially when they first start, and then there's a protocol of checking lithium levels as a monitoring as well. So lithium toxicity is something that can be asked in the interview setting. You may be asked that there's a patient with bipolar who is on the treatment, but suddenly they have come to you with feeling unwell. Symptoms can include some gastrointestinal symptom, loss of appetite, nausea, diarrhea, muscle weakness, drowsiness, confusion, tremor. In some worst cases, you can have fits as well, and coma and death. It's important again, to go systematically, look for other causes as well, look for their medication history. And if you find the patient has been on lithium, and sometimes patients are on lithium for a long time and they haven't really increased the dose, but still they can suffer with this episode. So if you find the patient has been on lithium, then you will send an urgent test for the lithium bloods to see the level, and if the levels are high, you will escalate it to the medical registrar and the medical team, because then again this condition will become a medical emergency and has to be looked after on a medical ward, because they will need supportive care and close monitoring from the medical team. Now, this rapid tranquilization is actually not a side effect, but this is something which we do on our ward sometimes. You may be given a scenario of a patient who is very, very psychotic and becoming very aggressive, putting themselves and others at risk. Rapid tranquilization is something that is used for that particular reason. But whenever you're using that, you have to again be very careful, starting systematically. To say that this, if you're using rapid tranquilization, that's the last thing we do. We need to find out what are the other causes that maybe which may be the reason why patient is so aggressive or agitated. Is there any pain, any infection, things like that? Any recent changes to medication which has led to them becoming so unwell. But if you think that there's none of that, the patient is because purely because of psychosis, you have to again consider safe prescribing regimes as well. Consider what medication has been prescribed to them in the past, what has been effective in the past. Then physical monitoring whenever you're prescribing high doses of any psychiatric medication, we have to consider physical monitoring, the physical side effects and those medications as well. So prior to rapid tranquilization, we have to consider non-pharmacological approaches as well to see if we can calm down the situation, that if we can avoid prescribing any medication. So if you like to learn more about rapid tranquilization, you can search the internet, but this is just a screenshot from one of the NHS trusts in UK, that medication they normally use. You can find this in the NICE guidelines as well. Lorazepam, which is benzodiazepine, is usually the first line, and most of the times we hope that this will be effective. If it's not effective, then we can use olanzapine and haloperidol as well. But if you're using antipsychotic, you have to be careful. You need to consider that you may need to monitor the patient more closely for any side effects and the things that can go wrong with antipsychotic, like, for example, doing an ECG to see if they have prolonged QTC and things like that. So if this situation is given to you in an interview situation about rapid tranquilization, you can mention what the things I've already mentioned, that trying to calm down the situation with using non-pharmacological approaches first, identifying why the patient is getting aggressive. Is there anything that you can do to identify any other causes which can lead to patient getting calmer, or if they are specifically asking for what medication you may use in rapid tranquilization, I think it's good to have that knowledge so you can give them some idea in an interview setting. So thank you very much for listening to me. This was the end of presentation. I hope it was useful, and good luck for your interview.